everyone. Good morning here in California, but I know it's good afternoon, good evening in different parts of the world. Thank you so much for joining Health for the World International Grand Rounds. It's my extreme honor to introduce the speaker today. He's one of the most accomplished people worldwide in radiology. His introduction is so long, but it took me some time to make it more concise. He is Dr. Borgstede currently serves as emeritus professor and was also the vice chair of Department of Radiology at University of Colorado. He was a past president of RSNA, American Board of Radiology, American College of Radiology, and International Society of Radiology. His interest in international radiology service led him to personally arrange and complete international service projects in Philippines and Cameroon. His family purchased and delivered diagnostic medical sonographic equipment to local hospitals and provided training for the staff, having a lasting impact. Through his work in all these international societies, he has contributed immensely to global health work. He's a recipient of numerous honors and awards throughout his career. He has received the Gold Medal and William T. Thornwell Award for Excellence in Economics and Health Policy from ACR, and there's a long list of awards also. Personally, I have been very impressed by Jim, not just by his accomplishments, but also because he's such a good human being. We met during the time when Jim was the RSNA president, and we discussed global health together, and I could make out how passionate and driven he is in global health. And such a good human being. So thank you so much, Jim, for giving this grand rounds for us. Jim will be talking about global radiology collaboration, challenges and conflicts.
Well, Bhavya, thank you for that wonderful introduction. And it's been great working with you in Health for the World and with RSNA 2020. That was great. And you did a wonderful presentation there that's well recognized. So as Bhavya said, I'm going to talk about global radiology collaboration challenges and conflicts. She's already mentioned some of my background, which gives me some expertise perhaps, and some opportunities to offer my perspectives on these topics. Hopefully by the end of this presentation, you will be able to explain perspectives of global health, identify conflicts in global health delivery, and then identify some resources for global health. First off, let's talk about perspectives. I might ask, why do we do what we do? We might do global health be involved for recognition. We might be involved for responsibility, perhaps service, perhaps from an entrepreneurial perspective, which is not necessarily wrong. But I would submit to you that the most important thing is to do the right thing for the right reason. There's an article that's often quoted, and it's 20 years old now, but still often quoted from the Annals of Internal Medicine, entitled Medical Professionalism in the New Millennium, a Physician Charter. And you might want to take a look at that. There are 10 commitments that they talk about to professionalism. It's commitments number 6 and 7, that commitment to improving access to care and the commitment to a just distribution of finite resources that are so important to what we're talking about today. And that commitment to access to care says, in part, the objective of all healthcare systems should be to provide a uniform and adequate standard of care by eliminating barriers to access based on race, education, finances, and geography, among other things. So let's drill down a little bit and talk about some of these reasons to engage in international radiology. And this is a little bit different topic than perhaps what Health for the World has done in the past, where we talk about modalities or organ systems. I'm stepping back here a little bit today. And I think these reasons to engage in international radiology can be approached from 3 different perspectives: a humanitarian perspective, a regulatory perspective, or an entrepreneurial perspective. And let's talk first about that humanitarian perspective, which is where the goal is to improve population health. Now, population health can be improved in 3 different ways. That can be by direct healthcare delivery, perhaps more in primary care rather than radiology. But in that situation, when the healthcare provider leaves, so does the healthcare. One might also be engaged in improving population health with basic education. Or you might be involved with this humanitarian approach and a goal to improve population health from a strategic initiative. And that's what the RSNA has been involved with so much. As we talk about some of the resources, bear with me just a second. I'm going to improve my screen, hopefully. As we look at global health strategies in under-resourced countries, I think these can be approached from 3 different ways: diseases, logistics, and conflicts. With respect to diseases, I think many of us who've worked overseas can identify with the areas that I've mentioned here and perhaps others: diarrhea, malnutrition, tuberculosis, malaria and other parasites, including HIV, hepatitis, hepatomas, and congenital anomalies. But I want to talk a little bit more briefly about COVID-19, because we're all involved in this, and particularly COVID-19 in the under-resourced world. And this slide, and I've given you the reference here, talks about global mortality distributions. And in the light blue, you can see that's reported COVID-19 deaths. And in the darker blue, the estimated excess deaths. And you can see, if you look at HIC is high income countries, UMC is upper middle income countries, LMC lower middle income countries, LIC lower income countries, and then lastly, the developing world. And you can see the reported COVID deaths are a little bit different place to place, but look at the dramatic difference in estimated excess deaths, comparing in particular high-income countries with the under-resourced world. Dramatic difference. Now, some statistics might actually suggest lower COVID mortalities in the under-resourced areas, but I would drill down on that a little bit more and ask why. Well, in under-resourced areas, there might also be underreporting. You only see what you look for, and there may be more deaths than we really realize. Some people have said, well, there's less deaths in under-resourced areas because it's a younger population with less vulnerability to serious infections. But there may also be increased risk factors in those areas with untreated hypertension, for example, and diabetes, and an increased population density, inadequate access to vaccines, and inadequate supportive care. But the problem really is health equity or the lack thereof. The definition of a pandemic, I think we all know, this outbreak of a disease that occurs over a worldwide geographic area, multiple countries and continents, typically affecting significant proportions of the population, a pandemic outbreak of a disease. And I say this because it emphasizes the fact that we're all in this together. What affects one person in the world affects us all. This is an example when we talk about diseases and we talk about under-resourced areas, illustrating the point that oftentimes there is advanced disease presentation. People don't present early in their disease. This was a patient I saw in Haiti, Port-au-Prince Hospital. Patient came in, advanced metastatic neoplasm, and said, "I'm just not feeling well," and 4 days later died. Talk a little bit about logistics as we work in under-resourced areas. I think there is a great need for the sensitivity and customs, need for local contacts, and if you will, sometimes incentives to facilitate healthcare delivery. We have to be sensitive to the language. Are we going to be able to communicate with our patients, particularly if we from a high-resourced area are coming to a lower-resourced area to work? And we might get as mundane to think about things like power sources. If one is bringing equipment to an under-resourced area, do you have surge protectors, power adapters, and so forth? And what about data recording and teaching aids? Will those be available? How will the information that we identify, particularly on imaging, be recorded? And then will those images be interpreted locally, or will there be teleradiological care? And I'll talk about that a little bit more later on. But I would submit to you that training has to accompany any equipment that is brought to an under-resourced area in particular. And preventive medicine is paramount. We in radiology think that radiology is perhaps everything. Well, I would submit to you that more than primary care even, preventive medicine is paramount. And civil engineers will trump healthcare workers in improving healthcare. But overall, the most important thing is sustainability. This is an example, Engineers Without Borders, where they go to under-resourced areas, provide water treatment, safe water, sewage treatment. And I would submit to you that if you can have safe, clean water and sewage treatment, you can avoid a lot of the diseases that I talked about earlier, that they won't be transmitted. I also like to think of healthcare in the under-resourced area in terms of where it fits with basic needs. And in my experience, working with multiple organizations and on my own, the most important thing that we all take for granted in a resourced area is food and clean water, followed by clothing, shelter, safety. And then at the top of this needs pyramid is basic health, medical care. And if we expand on the top of that pyramid, again, primary healthcare delivery and consumable equipment is very important. More advanced than that would be reusable equipment, and that's where imaging fits in. And at the top of that pyramid is teaching. It's the story about giving a man a fish, he eats for the day. Teaching someone to fish, they live for a lifetime and they eat for a lifetime. Some other parameters that many of you who are listening in, I think, can relate to, and I have to point this out to my colleagues in a resource country, is this concept of goodness. And what I call in a pejorative fashion, junk material might be donated by well-meaning people. However, if it's junk in an over-resourced, a highly resourced area, it's junk when you take it to an under-resourced area. And simply moving outdated books and equipment thousands of miles doesn't make them any more valuable or work any better. And instead, what I have found is if one can provide laptop computers and CDs, because many under-resourced areas have access to the internet, one is providing much more quality improvement of healthcare. Another concept that I had to get used to, and this is from Grace Children's Hospital in Port-au-Prince, Haiti, is the concept that everyone pays. I never envisioned such a thing, but here on the left side of this screen, and I don't expect you to read all this, are the lists of the various radiographic procedures that are done and what the expectation was for payment by the individual having that service. Ingenuity is so important in an under-resourced area. This on the upper left screen, my colleague Paul Ellenbogen and I at the top of the destroyed Grace Children's Hospital, Port-au-Prince, Haiti, shortly after the earthquake there in 2010. On the lower right screen is C2C, containers, cargo to containers. And this was a very innovative, ingenious approach to healthcare areas where healthcare can be delivered by the National Hockey League of all organizations, where they donated these cargo containers that are usually on ships, converted them to laboratories, X-ray rooms, exam rooms, and everything else. Very innovative. And I guarantee you that in the next earthquake, those cargo containers won't fall down. So now let's go back to our reasons for engaging in international radiology and talk about regulatory followed by entrepreneurial reasons to engage. And first, we'll talk about the regulatory reasons. And I don't, again, mean that in a pejorative way. I mean, this is very important. I've had the opportunity when I worked with the International Society of Radiology and was their president, working with the IAEA, the World Health Organization, and in this regulatory arena, there are many international societies, radiologies, and other NGOs that can provide regulatory and advisory approaches to healthcare. This is a print screen I recently made from the IAEA website where they talk about efforts to ensure patient safety during medical procedures using ionizing radiation. Now, many of us might think of the IAEA in terms of their work with atomic weapons and bombs and so forth, but the IAEA is very active in the medical arena. Eurosafe, another organization that's involved in the safe use of ionizing radiation, as is Image Gently from the US and Image Wisely, many organizations involved in Image Wisely so that we're using appropriate dosage on our examinations. There are many organizations that have appropriateness guidelines that can assist those countries without appropriateness guidelines so that we know when an examination should actually be performed. And I've listed some of those here. The American Board of Radiology and also the European Board of Radiology, among other organizations, will certify the interpreters of examination, that interpretation is being performed with skill and safety. So now let's move, as we talk about reasons to engage in international radiology, into the entrepreneurial area. And again, that is not necessarily anything wrong with that, but that can be done in two ways. There can be outreach. My organization, the University of Colorado, is involved in outreach, as are many organizations, or patients can actually be returned to the university or the organization. And I've just given you a couple print screens, Johns Hopkins and Mayo Clinic as examples, but there are many. So now, with that background, let's talk about some of these conflicts and challenges that we see in delivering healthcare internationally and particularly in under-resourced areas. And I've listed for you here, I think, 5 of those. This issue of insufficient resources or maldistribution of resources, like I showed you in that Annals article. Adaptability, the issue of analog versus digital storage and transmission, and the issue of dealing with governments that oftentimes prevent rather than promote healthcare by impounding or blocking equipment. And I would also submit to you, and I'll give you some examples here in the next few slides, that Western medicine has to be sensitive and collaborate with traditional medicine. So let's approach what I've just said from the perspective of some contrasting challenges that I can give you personal experiences with, but they're not unique to these areas. I worked, as Bobby said, in the Philippines at Silliman University Medical Center in Dumaguete City, Philippines, about an hour's plane flight south of Manila, where there was, unfortunately, government interference and corruption. But there was great Western collaboration with traditional medicine. There were 2 local radiologists and a number of primary care attendings and residents at that institution. Now contrast that with the Cameroon, the Presbyterian Hospital at Enongal, Abalawa, Cameroon, where there was government interference and corruption as well. But unfortunately, there was also some corruption at that time with the governing hospital body. And there was a conflict between Western and traditional medicine with a limited number of providers in all areas. And then you can compare that with Grace Children's Hospital, where there was, when we first started working there, and unfortunately, I think that continues, no effective government, and then a national disaster with the earthquake. And there was really token interest by outside groups in assistance. This is one of the early machines that my family and I took to the to Philippines and then subsequently to the Cameroon. Now we have much smaller ultrasound equipment, but I put this slide in here to illustrate the fact that, in my opinion, in many of the remote and under-resourced areas, when one talks about cross-sectional imaging, ultrasound is king. The diseases that can be treated can most often be diagnosed by ultrasound. So, talk a little bit more about my experience in the Cameroon. As I mentioned, there was really an adversarial relationship between traditional and Western medicine. Now, why did that occur? Well, 100 years ago, more than that, Enongal was the first patient that was treated by a Western physician. And this lady had a huge benign ovarian tumor. Now, she was told by the traditional physicians that she was a bad person and deserved to die. But she knew about this local physician, this Western physician, who had arrived a few years earlier, but had not had any patients as of yet. Patients were seeing the traditional physician. But she decided she would give this Western physician a try, because otherwise she was going to die. Well, the Western physician operated, took out the benign tumor, and she survived. And all the patients then thought this was a miracle and wanted to see the Western physician. And because of her success, many patients abandoned traditional medicine, and hence this adversarial relationship between Western and traditional medicine developed, which exists to date. Now, in that hospital where I worked, there were really no radiologists except for me, and there were 3 physicians for a 100-bed hospital. I say no radiologists. I had a colleague that I brought with me and one of our technologists. And here is that radiologist colleague that was working with a local technologist to repair an X-ray unit that the government had impounded. It sat on a dock near salt water, corroded for a year before they were able to pay the duty, if you will, to get that unit out of the customs, and the unit was not working. And so my colleagues worked to get that unit working, which they were successful with. This, I realize, is not the greatest X-ray. It was what we could do in the Cameroon. This Waters view skull and face, you can see opacification of the right maxillary sinus, some mucosal thickening on the left. Why did this happen? This is the patient and what the patient looked like. And the reason for this was trachoma. And this was complications from local treatment. This patient was treated by the local traditional physician by grinding up herbs, putting them in a blowgun and blasting them in the individual's eye, who is now going to lose or lost his eye and had sinus disease. Again, this patient sought late treatment, was told not to see a Western physician, the conflict between traditional and Western medicine. Different than what I saw in the Philippines, where there was this collaborative relationship. Now with Grace Children's Hospital, different challenges that we saw. That hospital was founded in 1967 for children with tuberculosis and then expanded to care for adults. But unfortunately, it was largely destroyed in the earthquake in 2010. Currently, there is a small inpatient children's facility with a large outpatient facility, particularly for women's and children's health care, and a large outreach for tuberculosis and HIV treatment. There were US and French trained radiologists. The 19 local radiologists had limited training, but they had training. There was unfortunately little collaboration in healthcare, or really anything else, with some threats perceived by local individuals for competition and actually sabotage of some equipment. And there was a temptation to bring interpretations of imaging back to the United States, which further enhanced conflict between the local healthcare and outside healthcare. This is an example of equipment that was donated by well-meaning souls, a CT scanner that never worked, no technical support was provided for that equipment, and it sat out on the sidewalk. Training does have to accompany equipment. We were successful in getting an equipment vendor to donate digital radiographic equipment for Grace Children's Hospital. It would work digitally or analog, and we were quite proud of that. We brought the equipment over, but unfortunately, we didn't give enough training as well. And the senior technologist used the equipment only in the analog mode. And when we went back, we found that all of the digital portion of the equipment was still sitting in a crate, because the senior technologist using the equipment, which was much nicer equipment than what he'd had, didn't use the digital capabilities because he didn't know how. Again, in Haiti, some contrasting practices. In Port-au-Prince, Radiolab. This facility would rival any facility in a developed, resourced area. Wonderful ultrasound equipment, mammography, functional radiographic equipment, CT, MR. Contrast that with what patients had to endure in the city hospital, their file room here, Grace Children's Hospital, destroyed by the earthquake, broken radiographic equipment, and imaging being done analog, and the images dried on a drying rack outdoors. So I want to close by talking about some resources. This is an article from Radiographics highlighting the RSNA's Committee on International Radiology Education, CIRE, and its 25 years of existence. The RSNA has been very involved in strategic radiology education. I've listed for you here 8 of the programs, international fellowships and grants that the RSNA has for individuals either to come to the US for training or for the RSNA to take individuals to an under-resourced area. Health for the World, a wonderful resource. And again, I want to highlight what Bobby and colleagues have done with Health for the World. Tremendous, okay? A resource that should be tapped. And RAD-8 is another example of bringing radiology to the world as well. But I think coordination of efforts is key. All these organizations have international efforts and counterparts, and many organizations that I haven't even mentioned have international efforts, and US and European medical schools have these international efforts. Unfortunately, there's a lot of duplication, and our goal should really be coordination and integration of these efforts for the benefit of our patients and not duplication. And that's particularly true in this humanitarian region, a realm. Now, Haiti is an example of a country that is sinking in the weight of equipment that has been donated by well-meaning souls, some of whom, I admit, do want to just check a box for service on their curriculum vitae, and some who only go once and start a project and never return, which is an approach that creates more harm than good. But a lot of this is just poor coordination that could be improved. So I'll close by asking that question that I asked earlier. Why do we do what we do? We might do it for the reasons that I've listed here, but again, to emphasize, the most important thing is to do the right thing for the right reason. I've enjoyed all of my work overseas. This is an example of working with a child with scrofula, and we were imaging this neck mass. You can see on ultrasound, large lymph node, high flow on color as well. But I want to close with this prayer that Bobby's grandfather said, Siva, which meant selfless service to help other people. And in that prayer, it goes, in happiness or sadness, in sickness or in health, in good or in bad times, no matter what, always do good for others. And I agree with that prayer. So thank you very much for having me here. And again, I want to emphasize that we're all in this world together, and together we are stronger. Bhavya, thank you very much.
Thank you so much. That was excellent, Tim. A wonderful talk, very enlightening. And I also love the message of working together and working stronger through collaboration. So, I really believe in the power of collaboration. So this is an excellent talk on global radiology, and this is different from our previous talks, but very enlightening, and clearly the audience is loving it. I had a question myself before we move on to the Q&A. I was very impressed, Jim, by the ultrasound machine, which you took to Cameroon and I think Philippines. So we tried to do it and we ran into some issues. How did you navigate carrying that machine to these two countries so well and using it to help patients,
Bobby, do I have to answer that question? I talked about incentives, and that's a euphemistic way of saying the word bribe. And I did that before 9/11. I'm not sure I would ever do that in the current environment that we're in. But I found that, working with local people was extremely important. And it took me more than a year to set up this program in the Cameroon and the Philippines each. And we were able to get local folks on our side of customs to help us get through customs and facilitate the expedite getting our equipment in. Now, in one of those countries, there was some exchange of funds. In the other country, it was merely finding an individual, a customs official who had been cared for by the person who was helping us get through customs.
I see.
And that made amazing difference. You can't do this parachuting in. Now in Haiti, and in some of the other work that the RSNA, the ACR have done as examples, we found it very, very easy to get equipment in. And of course, the ultrasound equipment that we brought to Haiti, fast forward a number of years, much smaller equipment, and we were able to get that in quite easy. It was there a matter of the distribution of that equipment once we got it into the country. But that was the way we worked things.
Right, that's excellent. Yeah. Dr. Rebecca Steinfexler is here. She works in Haiti. She is pediatric radiology at UC Davis, And in Haiti, we face a similar challenge. And our only workaround during the earthquake was to ask the supplier there. There was X-ray film shortage to supply the X-ray films, So, but getting it from outside, kudos to you. That's amazing. You could make that work. Let me read some questions here. So Dr. Olasoji from Nigeria, he said, I think this is the question is about equipment donation. I think it might be a comment. It says, I need more clarification. If it is junk in the developed countries, it's junk anywhere else in the world. I think some of the old equipments in developed countries can still be useful in developing countries. Many hospitals lack adequate X-ray and mammography, as well as ultrasound machines. Junks of these equipments from developed countries will be greatly appreciated and useful in developing countries. So Dr. Olanle thinks that.
Let me comment on that. And, I may have been a little bit too critical, but I'm sensitive because I've seen so much equipment donated without any technical support or the ability to repair that equipment once it goes to a country. And I think that's necessary as well. Now, I would agree that simply because something's outdated in the United States in the equipment area, it might still be useful if it is sent over in good repair and if there is the ability for it to be repaired when it breaks down. But
Right.
Simply getting rid of the old equipment by sending it overseas with no support really doesn't satisfy what is needed.
Yeah, I think you bring about an excellent point, Jim. I've noticed that as a trend that, companies are just donating the old equipment, which is not functional, which is not right because it's not useful. But as you said, if it's functional and if it's working properly, and if it's needed, as Dr. Olanle said, then in certain circumstances, it's a good idea.
Yes.
Other challenge, Jim, I think which all of us face in global health is we have a lot of industries, especially in AI, who are interested in helping in the developing world, and the question always is, okay, we can help bridge the gap, we can provide the training, and if it is cloud-based, it's okay because, then you don't have to deal with the customs. But if it is an actual equipment, I think you brought about an excellent point about the customs, the tax, which the recipient has to pay. Are there any other things which we should be more thoughtful about when working with industrial partners in like just new equipment donation,
Yeah, I think it is helpful, Bobby, to see if the large multinational vendors can leverage some of their authority and their expertise to get equipment into areas, and also working with organizations like WHO and IAEA. It may facilitate things rather than taking the local approach that I did. I'd like to expand a little bit on that AI comment that you made as well, because if you look, we're pretty sensitive in the US with the issue of interpretation of imaging with AI. And I happen to agree with that. However, if you look at sub-Saharan Africa, where there's very few radiologists, if you could have an AI read of a chest X-ray as normal versus abnormal, that's all you'd be asking for. And the local person knows that the patient has symptoms of tuberculosis, and the AI report says this is abnormal. That patient might, and the local providers who aren't radiologists might be willing to go ahead then and treat that patient with a positive chest x-ray because they've got an AI read, which is better than no read at all.
You're right. You're absolutely right. We have one of the radiologists here, Dr. Ivan Rukundo from Rwanda. He's, as you said, he's working on automatic chest X-ray detection in Rwanda with a startup there, which is based in MIT. So I think there's a lot of potential there. I completely agree with you, Jim. There's a question from Dr. Enrique Menoro from Mexico. In many countries, there's a need for more radiologists. How can we increase the number of radiologists?
Yes, I mean, I think that is a big challenge. We were successful in Haiti with restarting their radiology training program with collaboration with US institutions. And I would submit to you that it's not just the US. I mean, there are the opportunities with the European Society of Radiology to further some of the training. And I think there's a great interest in doing outreach in that regard. So I think those are organizations that could be tapped. And when I talked about resources earlier in my presentation, the European Society of Radiology, as well as the US institutions, and asking about training more radiologists and perhaps people who are radiologist assistants, if you will, who might be very sophisticated with primary care and be able to add additional training in radiology.
Are there any, I heard your comment about American Board of Radiology with accreditation of the radiologists, are there any international programs through ABR in which they can, certify international radiologists also?
The ABR does not certify international radiologists. However, the ABR has collaborated with organizations in Mexico, as one example, organizations in other countries to help them set up models for certification.
Okay, that makes sense. All right. There's a question about RAD-8 by Dr. Emmanuel Rudakamawa. What are the practical steps in collaborating with RAD-8 in the delivery of quality services to deprived population?
Yeah, RAD-8 is a great organization. I've known the individual that started RAD-8 from the time that individual was a resident at Johns Hopkins, Dan Malura. And I would suggest that you might want to contact Dan or go on the RAD-8 website. I think in particular, RAD-8 is a great organization with providing what I call intel services, sending people to our countries and being able to do needs assessments. And then they actually provide then, once the needs assessments have been done, provide contacts for care. They've done some work with providing PACS equipment for a variety of countries and for education. Our organization, University of Colorado, right now, Radiology, is involved in Nepal with RAD-8, but I would say contact RAD-8 through their website and Dan Malura. And
then that's excellent. There's a question about the learning centers at RSNA. There's a Global Learning Center program.
Yes.
How do our participants here, they benefit from GLC? Should they just go to the website and apply as a university for the program?
Yes, that would be the way to go. There's an individual, Karina Galvin, who works with that program as well. She's their senior most staff person, and they can give you the criteria that have to be met so that there would be a likelihood of success with the global learning centers. I believe they're still doing three. They're getting this program off the ground, the global learning centers. 3 programs, 3 years, I believe it is, 3 to 5 maybe. that again, with the idea of sustainability. You know, in the past, the RSNA had their International Visiting Professor program, which they've still engaged with in Mexico, but in other countries, they're working hard with also with this concept of sustainability. Now in Mexico, they've been back multiple years. There's sustainability, but with these global learning centers, that's what they're trying to do, rather than somebody go over with the International Visiting Professor program, stay a couple weeks and they're gone. This sustainability for multiple years.
The question about ISR, how can the radiologists work with the International Society of Radiology to collaborate?
Thank you for that question. The International Society is really an organization of organizations. It doesn't deal with individual radiologists. It deals with state, regional radiology organizations, not individual radiologists for impact. So you would need to work through your country's or your state's radiology organization, and they would have the interface with the International Society of Radiology. Now, the International Society of Radiology does put on conferences, and they particularly target under-resourced areas for their conferences to bring education involved. They have one coming up, and I can't tell you, I can't recall right off the bat where it is, but if you look at the ISR's website, you would be able to find that as far as education is concerned.
All right, thank you for answering that. Dr. Enrique Menry from Mexico asks, what's the importance of quality? I think quality QI programs in radiology in international sphere.
Yeah, I think that that's extremely important. I mean, my feeling is we all, as my slide says, we're all in this together, and everybody, wherever they are in the world, deserves quality care. You know, we have to be very sensitive to that we're not giving them second-rate care in the care that we do give. I recognize that every place isn't going to have a University of Colorado or a UCSF radiology facility, but the care that we provide has to be provided with quality. And you can look at some of the quality resources that I mentioned in my talk. You know, the ACR has those, the RSNA has some of those, the European Society of Radiology, the appropriateness criteria of many organizations. I think those are all examples where there can be quality care provided.
Thank you so much. And as far as the QI, we also, you absolutely agree with you, Jim. We have an international QI paper through Health for the World, which is in JACR, and it basically, you know, talks about how the QI programs can be beneficial in different continents, and the resources which Jim talked about are excellent. So I think as far as the questions, those are the only questions, but I'll read out some nice comments from the chat box, because the chat box is like bursting with great comments. Dr. Nayana Patel, who you know from Colorado, said great talk. And then Dr. Betseda Sanchez says, wow, Seva, excellent talk. Dr. Flavio Ernesto Trujillo Samudio said, thank you so much for your commitment and helping these countries. Dr. Lopez Oviedo said, thank you so much. Greetings. Dr. Enrique Menro says, excellent lecture, congratulations. Dr. Olanle says, thank you for your contribution to humanity. Tito Rivera says, excellent presentation. Dr. Cleanham says, thank you so much and great support for LMICs. Dr. Amaka says, hello from Nigeria. Dr. Aditi says, thank you for sharing your experiences, enlightening to know the unique challenges faced in developing countries and ways to overcome them. Dr. Ibrahim says, thank you so much for insightful lecture. I think the comments keep going on, otherwise you'll be just reading them.
Well, it's interesting, Gravia, that some of those people are people that I've worked with in these organizations and overseas. So,
Yes.
you know, it's interesting to hear from them all.
Yeah, and Dr. Amal from Ethiopia says excellent talk too. There are more comments popping up, but and Dr. Rebecca Stenflexer from UC Davis also says excellent talk. And Dr. Lena Lambert, who was a part of the first radiology residency program in Zambia, says very encouraging and motivating discussion. All right, I think we should stop, otherwise we'll be here
Yeah,
for
I think
hours.
that's fine. I want to again thank you and Bhavya, and Healthcare for the World, Health for the World, for what you've done and for the opportunity again to present.
Thank you so much. I really feel grateful to our Health for the World community, including you, Jim. You have done a lot for Health for the World, and our excellent community who you are meeting virtually today. Each of these radiologists in different parts of the world make us who we are today. They are like our family. So thank you, everyone, for joining. Thank you so much, Jim, from my heart, for an excellent talk. We were honored to have you and hope you have a great day. Thank you so much.
Same. Stay safe.
Thank you. You too. Bye-bye.